I'm Murphy. I'm a second-year occupational therapy student, and I welcome you to COTAD SUNY Downstate Chapter's first campus event. COTAD stands for the Coalition of Occupational Therapy Advocates for Diversity. Dr. Arameh Anvarizadeh initially established the COTAD Chapter Program in 2017 as part of the COTAD mission to meet society's occupational needs by developing local and national initiatives and aligning with key stakeholders to create a socio-culturally diverse workforce that is able to provide cultural sensitive and client-centered services to occupational therapy consumers. COTAD chapters are designed to support occupational therapy students to work together to develop and promote diversity and inclusion within occupational therapy education programs and in the profession. Each chapter is designed to create opportunities and resources to foster open conversation and increase awareness of different lived experiences to increase cultural humility. In 2018, Downstate was the first academic institution to have a COTAD chapter in New York State, let alone the entire East Coast. This chapter was developed by SUNY Downstate occupational therapy students and their faculty advisor, occupational therapist, Vikram Pagpatan. Our mission is to spread awareness of diversity and inclusion to various healthcare professions with Downstate and our local community. Although we are a new organization, we have had 3 previous successful events thus far. In November 2018, we hosted a holiday toy drive in order to raise awareness about COTAD and the need for cultural diversity. Last week, we hosted a COTAD party fundraiser, which was to raise overall awareness about COTAD and fundraise for future events such as this one. And in the future, we plan to work with local homeless shelters to create programs to help them build resiliency skills and come into a more happier, not happy, but just build resiliency skills within the children and their parents. COTAD had a lot to offer Downstate and the local community, so please stay tuned for what we have in the future. After this panel, we have a reception to follow in the special functions room, and we ask that all audience members stay seated until our panelists leave, and then you guys can follow them. So at this time, I would like to formally introduce you to our moderator this evening, Dr. Jasmine Thomas. Jasmine Thomas is an assistant professor and the director of clinical education in the occupational therapy program at SUNY Downstate. Her clinical expertise is in the area of pediatrics, evaluating and treating children from the age of 0 to 21 years of age with various diagnoses. She is passionate about promoting and improving equal access to healthcare for all people. So without further ado,
This is such a valuable event, and thank you for hosting it. Talking about culture and inclusion and diversity, and just including all people in healthcare. It's such an important topic because we know that access to healthcare is deems on how someone can be productive in their lives. And today I'm honored to be up here on stage with a fabulous bunch of women who are they are professional and they are prestigious in what they do. So I'm gonna have them introduce themselves so you get to know them a little bit. They will say their name, where they work, their clinical expertise, and also their title of their job. Should I start with you? Yeah.
Hi, good evening, everyone. My name is Medea Akhtar. I'm the Assistant Vice President for Student Affairs here at Downstate. I've been at Downstate for about five and a half years. Prior to being at Downstate, I was the Director of Student Affairs at NYU College of Dentistry. As part of my job, I was part of the core faculty. I taught dental students diversity and cultural competence, specifically topics about what you're going to face when you get into the clinic that no one talks to you about, that no textbook can sort of prepare you for, what sort of backgrounds that you're going to come across, what sort of experiences and feelings and thoughts that you are going to have when you are working with patients of different backgrounds. Specifically, my education, I have a PhD in cultural anthropology, so really that's where my happiness is. This sort of stuff is oxygen for me, so I'm looking forward to this discussion.
Hi, I'm Ronnie Lichtman. Thank you to COTAD for inviting me. I'm very humbled to be here. I'm the chair of the midwifery program here at Downstate. I've been here about 16 years, I think, and even though most of my career has been in education, I've always practiced clinically. So right now I work in a clinic in Fort Greene, Brooklyn. I do antepartum, which is prenatal care, and family planning and gynecology. I've worked at North Central Bronx Hospital. I've worked at Harlem Hospital with many, many, many diverse populations. I'm recently, not recently, but I think the term has recently evolved, so I've recently become extremely interested in the issues of reproductive justice. I've always been interested in social justice, and now it's been focused, I think, on reproductive justice, so that's one of my areas. Yeah.
Hi, I'm Bridget Esport. Interim chair of the Occupational Therapy Program and Associate Dean for Strategic Initiatives. And as far as my work, it involves, I just love premature infants. Those little bitties are the children that I enjoy working with. So as most of you know, I'm a pediatric occupational therapist, and I've worked always in underserved communities, and talk more? I mean, not more, I mean, louder.
More into the phone.
How's that? So I worked I basically worked and actually still work in the neighborhoods that most folks do not want to work in. So we're talking Harlem, Spanish Harlem, Washington Heights, Hamilton Heights, basically what we call the hood. So those are the neighborhoods where I've contributed most of my work, and today I volunteer, some of you know, at the outpatient NICU clinic here at Downstate once a month, and that is an opportunity that I'm grateful to have, and it brings me a lot of joy to work with these families who are still not sure how to deal with their child once they come out of the NICU. So thank you, COTAD, for inviting me, and look forward to this conversation.
Hi, guys. My name is Dr. Clover Hutchinson. I am the current chief occupational therapist at Brookdale Hospital. I've been the chief for over 20 years. I know you look shocked. and I've been a therapist for almost 27 years, so I've been around for a while. My mantra really is advocacy is my passion. I am on the Board of Trustees for NYSOTA, and I'm also the president for the New York State Black Occupational Therapy Caucus. So that's how I actually got invited here. I've met a couple of the students who supported our events. I wanted to say thank you, guys. My primary background is really hands outpatient. I'm doing less of it now, just as we're getting bogged down with more administrative stuff, with the new changes. So you guys are gonna come to understand, like when we became therapists, we only focus on treatment. Now you have to understand insurance. So, and that's a whole new beast that we're about to embark on. So I went to York College, so Vic and I are alums. That's where I got my bachelor's. I did my OTD at Chatham in the last 3 years. So I think that this forum is quite interesting. I was exposed to COTAD maybe a year ago, but didn't really follow through. I kind of went to the website and often look at the comments and the conversations that was taking place. So from that, for now, one of the things that I'm most passionate about is just health literacy is one of the things I work on a lot. We do a lot of stuff at Brookdale Hospital. We have our health safety day, and people think I'm crazy, like, how can you talk about that all day? But I can, because I love it. And then my next thing really is understanding what you guys are talking about today about implicit biases and, you know, those kind of things that affect a large group of people. Okay, thank you.
Oh, good evening. My name is Dr. Virginia Anderson. I did my residency at Kings County. I consider that one of my best pieces of good luck, and I love being in Brooklyn. I love Brooklyn people. I was a medical director at Lutheran Medical Center for a few years, and I was here through the AIDS epidemic and was very active in outreach and AIDS prevention and trying to bring in grant money and all of that stuff. I am also a pediatric pathologist because one of my passions is to try to understand the diseases so we can help fix the patient better. And in order to do that, you got to really understand the mechanisms that cause the suffering that the patient has. I was fortunate to teach to the PT students here at the CHIRP. I did that for about 5 years. I recruited some students and got them active, and they enjoyed it very much as well. They have a pathology course, actually. We're one of the few PT schools that does have a pathology course, and I headed that up. And I tell students, I said, just don't sell your pathology book, because when someone comes into your gym and they have a diagnosis on the chart which comes with them, you better read about it so you know what the challenges that patient has. Because the patient is bigger than their diagnosis. But you need to understand the diagnosis so you can figure out, well, what do I got to look out for? What are the signs and symptoms of somebody having a heart attack or something? There's a clinical aspect to your work. Once you put on a white coat, nobody really cares what letters you have after your name. They just want the information. And to your neighbors, you're going to be someone people will look to for understanding, because you are part of the profession of taking care of others. And so the more you do that, the stronger your clinical skills will evolve, because they will be responding to a real human being that desperately needs you. And so I will talk some more. We're going to talk some more, right? All right, I'm going to sign off now, and thank you for coming in. And thank you for inviting me.
Thank you, everyone, for sharing. So we'll jump right into it then. So as healthcare professions or soon-to-be healthcare professionals, you have heard the word cultural competence. But what exactly does it mean? And there are so many different definitions out there of cultural competence. So I'm going to ask each panelist if they could give their personal definition of cultural competence. This first question will be answered by each one of you, and then afterwards, the other questions, you could just jump in as you feel fit, or if you feel you have passion about that specific topic. And then we want this to be an open discussion, so feel free to respond to each other as well. But we'll start with the definition of cultural competence.
Really, it wasn't a good idea to go next to you. It's always good to start first. To me, cultural competence, I think it's become a little bit of a buzz phrase. And when things become buzz and hot, they become a bit intimidating. I don't necessarily think that it's sort of a specialization or a certification. I think it's sort of an ability, it's a frame of mind. It's this idea that you have to be open to difference, and you have to be self-aware and introspective. And so when there are interactions and feelings arise and there's conflict or disagreement, it's being able to be open and standing back and listening and understanding. It's as simple as that, but it's as complex as that also.
So I'm going to be a little bit, in my past, I've been the rebel, so I'm going to be a little bit of a rebel. I'm not going to define cultural competence. I'm going to tell you what I call it, and it's a little different. It's similar. I call it cultural humility and respect. And I didn't make that up. I got that from somebody else. But it really speaks to me in a different kind of way. Because you're not, first of all, in this city, you can never be totally culturally competent, because I have worked with people from literally almost all over the world, and I can't know about all their cultures. And I can't know how somebody sitting in front of me or standing or lying on a bed in front of me defines their own culture. I can maybe guess, but I can't know that. So if and the other issue is that it's an interaction. So I have to realize that we all have a culture, and it's not the patient's culture that we're trying to be competent about. We are people interacting from a variety of cultures, and we all represent many cultures. And so the person that I'm interacting with may not understand my culture, and that person has to I have to realize that they are seeing me as a representative of Western biomedicine. And that may be something that they're not familiar with, not comfortable with. I'll give you two quick examples. In my clinic, I see many women from other countries who have had 2, 3, maybe more children. They may not have had prenatal care. for those births. They had vaginal births, everything is fine. They come to this country and we tell them they have to come to the clinic this many times. They get their bloods drawn, they get pelvic exams, they get invasive procedures, and 40% get a cesarean section. So they may not respect or want to be part of our culture. And that's why it's an interaction, and we have to be humble and realize that we represent a certain culture as well, and it's an interaction. I'll give you one other quick example. When I was doing an international project in Nicaragua, and it was a midwifery exchange, and the midwives there were not outrageously educated. Some people called them traditional birth attendants, but they would tell us about the women they cared for, and they'd say they don't want to come to the hospital because they heard you get cut in the hospital. Now, we tend to make all kinds of cultural assumptions about why people aren't coming to the hospital. They don't have transportation, they don't understand the language, but these were women who made a conscious decision, an informed decision, not to come to the hospital because they didn't want to be there, because they didn't want to be cut. And those are the kinds of issues that we don't always think of. We think of how can we respect what somebody eats, or how can we respect what somebody wears, or their holidays. It's much, much deeper than that. And it's an interaction of sometimes conflicting cultures.
I see cultural competence as a finite term. So it connotes that it's something that can be achieved. And I'm not certain that that's actually possible. So like Dr. Lichtman, cultural humility may be a term. I tend to use the term cultural effectiveness. And so if we're going to talk about that, I would say that I personally define cultural effectiveness in 3 parts. 1, being aware of your own biases and prejudices. 2, being supportive and affirmative of people who are not part of your cultural group. And then 3, intervening with yourself and with others in the presence of someone someone's culture who is being invalidated or attacked.
Nothing left for me to say now. Okay. So I agree with the ladies that have spoken so far, that definitely cultural competence is not something I think that can be achieved. I think it's an ongoing process. And when I became a therapist, the issues were there, but it's now so much in the forefront that we're faced to deal with the different issues, again, I would say, that we're facing. I know, for example, for me, the most important thing is to accept that there are differences and to be respectful, to be aware, and to be sensitive. I know, for example, I work at Brookdale Hospital, and everyone says, that's Brownsville, that's East New York, and there are a whole bunch of negative connotations that can go along with that community. And I always tell students that you are going to find yourself in a situation where you may be biased. It's just, I think it's unavoidable. I think it's for you also just to acknowledge it. One of the biggest things I used to say is, in OT school, they say, well, your job is to take you back to a prior function. So, we had a lot of thieves, guys who got injured because they were in the act of committing a crime, and they would come to therapy. And my first initial, when I became a therapist, was, why? Why am I going to make you better to return you to this job? So, you have to be sensitive and understand what your focus is.
Well, first of all, we have to be competent. We have to be good at what we do. We have to have confidence in how we do our tasks, your OT tasks. All tasks are valuable. So everybody has a gift. But if you're going to present yourself to people, then you need to be able to do whatever it is you're supposed to do. And so that gives you a sense of well-being, and you're convinced that you are able to be available. So having an always available attitude is a very good thing. And cultural, we're blessed, we're in Brooklyn. We are surrounded by so many cultures. We're in one of the most diverse areas anybody could ever live. And I think we have to enjoy that, because if we celebrate somebody's difference, then we get to share that difference, and we grow our souls in that manner. And different people have different ways of responding, but the most important influence in your life is your mother's lap. Because there you really learn what we do in our family and how we celebrate our holidays. Easter's coming up. You're going to paint some eggs. I mean, that may be in some families, but not in others. So I think understanding culture in the most broad way. Now, I had a serious problem, you see, because I'm a white person, and I grew up in a neighborhood, you know, where my extraction is Irish and German and Swedish, and I always wanted to be foreign and interesting, and I always wanted to have another language, and I'm terrible in language. I mean, what did I study in school? Latin. You don't speak that. Well, that's why I took it. Whenever I interacted with people, I had the pleasure of being the medical director at Lutheran Medical Family Health Center for a certain period of my life, and I learned so much from the Puerto Rican community there. What they taught me was personalismo. Never heard of it, but I saw it, and I couldn't figure out their ability in an instant to connect, be present, and if you were kind to them back, I mean, you had a friend for life. And so, you know, if you come from a culture that is not expressive, and then you meet these people and you say, hey, that, you know, that's pretty good. So you can pick up parts of other people's culture. You can go down the block and have somebody's Italian dinner. You know, so people invite you, because Brooklyn is a very open attitude. People invite you to their church, you hear their music. And so I think being from Brooklyn, we have you know, we're born with, it's part of our birthright to be culturally competent. And I think we should treasure that and find out how we can share what we have and other people can share what they have. But I think before you can be successful in this, you know, Socrates, who's a very famous Greek philosopher, he said, know thyself. So you got to know yourself, what your values are, how you identify, and how you can use those strengths to connect to other people of a like mind, or understand if some people just don't like you, and that can happen more than once. And I think if you concentrate on being available, and especially we're in a healing profession, where we have to be present to people, and learning how to do that, and do it very quickly, especially when you're busy working in the Kings County emergency room. You got to learn how to do that pretty fast, make the connection. Because if you don't make that connection, then no clinical encounter can occur. And it's a skill that is one of the fringe benefits of you being in a healthcare profession. And once you put on a white coat, you know, you're in the club, and you've got to walk the walk, talk the talk, sing the song, and let whoever it is you're taking care of know that you are for them. And then you can share with them what your gifts have been, because you have a good education, so they can learn how to do things better. And so it's a sharing and a partnership, and it's an opportunity for tremendous growth. And I used to tell the kids who were coming here to medical school, I said, you know, if you want to be a really great doctor, it's very simple. All you need is a compassionate heart and a healing hand. It's going to happen even if you don't do anything else, you see. And so that's just an attitude as you approach people. And you have to learn how to tame little kids, otherwise you can't examine them.
Thank you, Dr. Anderson. I'm going to hold up on that because I feel like you have a ton to share, and I'm going to continue asking some questions.
Sure.
I really heard some powerful statements and definitions of cultural competence, humility, respect, simplicity, being effective, but I also heard the other side, conflict, bias, differences, and, you know, the complexity that you said is so simple but complex. That's what you said, Medea, and I do agree with that. This is not an easy topic to think about and then also act in. So my next question to whoever would like to open up the floor is, as a clinician, how do you adapt to the specific needs of a patient when they present with cultural barriers that you cannot personally identify with? They just seem so foreign to you. So I'll say the question one more time. As a clinician, how do you adapt to the specific needs of a patient when they present with cultural barriers that you cannot personally identify with?
Can I counter that? I'll tell you how you can shut a patient down. It's by telling them they're wrong. What they're doing is wrong. What they're doing, what their beliefs are, how they practice something goes against the research that Western medicine has taught you. That's really one way of closing that open door. So I guess I would love for someone to talk a little bit more about how to counter that.
I'm going to tell a story about my own interaction. One was when I was a new clinician, and one was just last week. And the cultural barrier was similar, and it had to do with body image. And that wasn't how I was coming from it. I was coming from it from the medical perspective, or as a midwife, the healthcare perspective. Certain weights are good for you, and you should be within a certain framework, and you can have higher risk for illnesses if you are not in that weight, in that what we call the normal weight. So I had a 15-year-old patient who I had taken care of throughout her whole pregnancy. So we were good buddies by this time. And I was working in a clinic where if you were 17, you were too old for my clinic and you had to be pregnant to be in my clinic. So she was 15 and had just given birth, and she came in for her postpartum visit. And she gained a fair amount of postpartum is after pregnancy. She had gained a lot of weight in the pregnancy. And I was imagining, she's 15, I don't know how many more pregnancies, she might have, but by the time she's 40, she's going to be quite overweight if she doesn't lose the weight, and at risk for quite a number of diseases. So I just introduced my bias and my approach, and I just asked her what she was thinking about to lose the weight. And she turned around and she looked at me and she said, "Ronnie," and she was really angry, "I have finally reached the weight I've always wanted to be my whole life, and now you're telling me I have to lose weight?" Because I come from, you can't be too thin, you can't be too rich or too thin. But I'm white and I come from a different culture. She was a Latinx young woman. And she sure shut me up because I thought, well, we're coming from a very different perspective. So I kind of explained to her where I was coming from, and she just said, "I'm not doing it, I'm not losing weight." And I said, "Okay." And then a week ago, I had an older woman in my clinic. She was probably in her 50s or 60s and has diabetes. And her body mass index, her BMI, puts her in the obese category. Not quite in the morbidly obese, but close. And I'd handled it totally differently. I was so proud of myself because I didn't say, "Let's talk about losing weight." I asked her. I started out by asking her how she felt about her weight. Was she interested in losing weight? Did she want to lose weight? Now, this was a person, and this is a real cultural difference. I was laughing at myself because her body mass index is almost in the morbidly obese, and she said, "Well, I don't want to look like a stick, And I had to laugh because I come from, you can't be too thin. And she could have easily lost, from my perspective, 50 pounds and not looked like a stick. But I didn't pursue it. I just said, well, there's some literature that says if you lose weight, you can do better with your diabetes, but if you're not interested, and she said, "No, I'm not interested." And we ended up, the rest of the visit was just fine. But what I had learned over the many years, and I won't say how many, of my career, was that I can't just impose this on her. I couldn't tell her to lose weight. I couldn't start the way I started with my 15-year-old and said, "Okay, how are we going to lose weight?" I had to find out. It's actually called motivational interviewing, but I had to find out if she was interested and whether or not she wanted to. So that's just two examples from a very experienced practitioner and a very inexperienced practitioner, how we can do things poorly and how we can do things a little bit better.
No, go ahead if you have
I
something
guess
to
I
say.
didn't mean to do it in order again, but I was trying to break it up a little bit.
Oh, you know what? We're going to hold the questions off until the very end, but hold on to your question. We'll get to you.
For me, I just ask questions. I found that's always helped me. And so I'll give also a little example. So I worked with a toddler boy, and the family was a Pakistani family. And father didn't take to me too much. And the father answered all the questions, which I'm fine with, and you all know me that I always talk to both parents. But of course, I'm expecting for the mother to answer some of the questions, and this was a relatively traditional household. Now, with this particular family, and I use that word particular because I'm not going to say the stereotype that all Pakistani families are like this, right? But in this particular family, for me to get the father to trust me and to value what I can contribute to his child, I started to just ask questions. What do you want your child to be able to do? What do you see for him in the future? Those types of questions. And then I took, because I actually have a penchant for languages, Dr. Anderson, and I started to learn Urdu. I don't remember any of it, so do not ask me, and do not ask me Dr. Akhtar, because I do not remember any of it. But I started to incorporate that in my sessions. So I started to label things in the environment and use words that I knew they commonly use in the household. And more I started to get, call it buy-in, call it participation, whatever, from the family, or in this case, more specifically from the father.
You know what? Do you want to wait off until the next question?
Yes, that's fine.
Because Dr. Jesper, you said something about the word stereotype, and sometimes we take our stereotypes to try to pretend or try to seem culturally aware. But how can we as providers try to be culturally aware without being perceived as stereotyping someone? I know that could get a little complex, I feel. And I love your, asking questions is something that's great, but what else have you guys done to make sure you're not perceived as stereotyping a person?
I think it's actually simple, even though I know we've talked about complex concepts. I think it's simple. You actively listen, you ask questions, and you treat people like human beings. Mm-hmm. And once you do that, and you create an environment that's affirmative, you're good.
I definitely agree. I think part of it is just being open and getting to know the culture. Mm-hmm. I do home care, and there is the agency that I work with. For a while, I was seeing a lot of Pakistanis, Bangladeshi family. And the one thing I have discovered, maybe it's a fault for me, but I find something that the family likes to do. So one particular family, the mom loved to cook. And guess what? I love to eat. So that was like a perfect relationship.
I know those households.
So I mean, and part of our thing was we had feeding goals for the clients. So so I worked around those issues. And I remember one time she was feeding, and I am not familiar with when she would take the rice, for example, and she just keep mushing it in her hand. So at first I was like, what is this, And so, I said, do you want us to have feeding with utensils or feeding traditionally? And for her, it was with utensils. So moving from that point on, we weren't doing the hand eating with the rice, we were using the utensils. So, it's just, let's just say, getting buy-in and just don't, I have coworkers who they would never eat the food. They don't even take water when they go into these homes. And I think the family, they're very perceptive. They know when you're not fully engaging with them. And so, that has been a strength for me, and I remember the birthdays. I remember just the little things that would get the family, where are you coming today? It's Christmas. They even buy into my holidays. Mm-hmm. So that makes it a lot easier also.
Can I add something to what you said? When you talk about cultural barriers, right, people who are really different from us, what are we really talking about? Cultural barriers are visible barriers. People who live different, look different from us, people who wear a headscarf, people who are of a different skin color, people who have a different English as a second language. It's something that's very, very visible. Has anyone heard the notion of the other? Right? So this idea of the other is that you look at a group of people, you look at a practice, you look at a culture, and you automatically decide that it's very different from you, and because it's so different from you, you push it aside as something that you can't connect to. And all of a sudden, those people, right? Mm-hmm. So it's this idea of grouping people. And so when you talked about learning specific words or being open to their food, they're seeing you as having accepted them. And going back to what Dr. Anderson was saying, compassion. People see real sincerity. And another thing Dr. Anderson said, which I really resonated with, is that while you should be compassionate, it's very, very important to be compassionate. The one thing that I think rubs off a little bit more is being aware of who we are and what our thoughts are and what our biases come out and how they come out, I think is really important too.
And I want to second what people said about listening, because we tend to, and maybe we've all been invited on this panel because we're talkers, and we do tend to talk a lot when we're in interactions with our patients, and we do tend to think that we have the answers and we have the knowledge, but there is nothing more important than listening, and the relationships that you establish, like when I was telling you about the 15-year-old earlier. Even though she was angry at me, she still came back for care, and we still had a great relationship because we had established that already. And so if we had a little difference, it wasn't something that we no longer were relating to each other. We still were relating to each other, and we were still caring about each other. And it is really a two-way street. And if you just listen, and you try to be quiet sometimes, it's hard for some of us, but try to do that.
Dr. Lichman, this is a perfect segue into our next question, actually. So, we're up here talking about strategies that we have, that we've used, but we've also developed these strategies over time. So we're not perfect in cultural competence. It's something that we continue to learn. But and Dr. Lichman, you talked about a mistake you made earlier on, but sometimes these mistakes, we're still working with the patient, and either they could shut down or we could shut down because it was a blatant mistake. So my next question is, can you share an instance in which you made a culturally insensitive mistake, and then did you take the time to address it, and how did you do it? I'll say it one more time. Can you share an instance in which you made a culturally insensitive mistake? Did you take the time to address it, and how did you address it?
Well, I'll tell you a story. A culturally insensitive story, which had consequences which you'll enjoy. It was Christmas time at the Sunset Park Family Health Center, and I was the medical director. So I had this very handsome dentist who was going to be Santa Claus. And not to be outdone, I decided to be Mrs. Claus. So Santa Claus comes with this gigantic beard and this big hat and all these to-dos. I just had a little jacket, and I had a Santa hat. And it was really funny because the next day I'm in my clinic and this kid comes, and I hear her out the door, and she's saying to her chum, she's about 5, she said, "My doctor is Santa Claus's girlfriend." And the other one says, "Santa doesn't have a girlfriend." So she says, "Why not?" So I had to learn cultural things from these kids because they were putting it right out there. And so what I figured out when I analyzed the situation, because none of the kids would pick up a present from Santa with the beard. They all came to me because I didn't have a beard. I was a person. So I could relate to them. But Santa, with the regalia, nobody got a present for him. So you better believe we didn't do that the next year. We had people show their face, and they could relate to that, and that worked out just fine. But I'll never forget that child. My doctor is Santa Claus's girlfriend. Wow, I said, that's pretty important. So that's a cultural insensitivity which led to a corrective action, because in the Spanish cultures, they celebrate 3 kings. They don't really have a big to-do about Santa. And so we had to then modify that. Now, we still had a Santa hat or something, but everybody was very happy to get their presents, but it was remarkable because we had lines of people going, but no one would go to that guy. I mean, he wasn't for real to them. But they saw me smiling at them, and they were very happy, and I was glad to be there. So you pick up things as you go along. But if Santa Claus is around and he would like a girlfriend, I think I'll apply.
Okay. My first job as an OT was first Harlem, but eventually I ended up at Lincoln Hospital in the Bronx. And then I didn't have a car, so I would take the train. So I learned all my Spanish from the signs and stuff in the train. So when I got to Lincoln, it's a Spanish neighborhood, and it was a lot of mommy and pappies. And so I just was always mommy, pappy, and, so for a while, my colleague was saying to me, why do you keep saying that? I said, well, I hear them saying it, because I took it as a term of endearment. Some liked it, but when I got to Brookdale Hospital, a lot didn't like it. So I had to learn that, certain slangs have different meanings to different groups. And so I don't do the mommy puppy thing anymore because it's not appreciated. Yeah.
Well, one of the things that we do in our clinic a lot of is family planning. And so I've had patients who I've asked about their family planning method, and it turns out they don't need it because they're lesbian. And I think the first time I did that, I was quite embarrassed, and I just apologized. And so now I make sure that I ask people questions so that I don't make assumptions about their sexual orientation before I get into launching issues. I thought, of course, I'm asking them about family planning. I'm not telling them what to do, so I'm being sensitive and I'm being understanding. But lo and behold, a number of my patients don't need family planning because they have same-sex relationships. So we still talk about safer sex, but I had to learn to get the information and not to make that error because it was, people. I mean, I don't think anybody, nobody walked out on me ever, but I did feel that, boy, I sure made a mistake on that one.
Yeah, so I think, what you're talking about is learning and owning up to our mistakes, and that's okay, but apologizing and that Santa Claus story is like, yeah, we're all human, and we're going to make those mistakes as well as clinicians, as practitioners, but what do we do with it? Do we address it, or do we let it be the pink elephant in the room and then hope that the patient doesn't walk out or, gets too upset or, talks about us to another patient? We want to be able to address it, even though it's very difficult. And so that leads me up to my next question. As I said, we are all human and we all have our own biases. And most of the time we have our clinical hat on and we are able to maintain that professional demeanor. But what happens when a client really triggers one of your hot buttons that's, something, a bias that you have or a belief that or insecurity that you have about yourself based on stereotypes? So I know it's a little bit of a pointed question, but how do you react to that and handle that as a professional when someone triggers your bias or something that's based on stereotype that you have internalized about yourself?
I can answer that.
Sure.
Well, when you work in a busy inner city clinic, there's always something happening, right? So what you've got to try to do is become a partner with the patient. And how do you do that? Well, it's not always easy, but they will come around if you're kind to them and speak to them in a quiet voice. And what I try to teach my young doctors is that they should always bring somebody else into the room. So it's not just one-on-one. So if you're feeling tension, you're feeling somebody's unhappy with something, if you bring somebody into the scene, that breaks the ice immediately. And then there's another person, another point of view, and another way to engage in the conversation. And so you can dispel a lot of problems. They just melt down when a person feels they're not alone, with someone who maybe they don't think fully understands them. So that's a very important trick to do, especially when there is tension between a doctor and a patient. And that can happen, and they get very, very upset. And so if you learn that trick, that's a very, very good trick, because especially if it's someone who is culturally related to the person, like bringing a nurse who speaks Spanish, who is able to engage. And then there's a camaraderie there, and then somebody then becomes your friend. Or sometimes you can rescue a patient. Sometimes the tension is very severe, and so you can just go in there and break the ice and, try to make the peace. It's a skill everybody needs to develop as they grow their professional life.
Can I add to that? I think that as the healthcare provider, you sort of bear the burden of responsibility of having to be culturally sensitive. Guess who doesn't have to be culturally sensitive? Your patient, right? And so there are so many patients who may not respect you, may not speak to you, may not address you as their authoritative healthcare provider because of the way that you look, because of who you are, because of your gender, because of your sexuality, because of how you dress. And that, for me, is absolutely the most challenging experience I'll have. I'm not a clinician by any means, but in my own personal career, I feel that my gender and my age, so to speak, this whole you look like a student kind of a thing, it is a huge trigger for me, because I'll have even, people in upper administration call me sweetheart. And it just makes me crazy, because what they're doing is they're reducing all of my qualifications, my competence, what I've worked for, and just looking at me as this cute little girl. And so I use that example so that's something relatable to you in the clinic, because you will come across patients who you will have those experiences with. And the one thing that I'll tell you is that you pick your battle. And it's sort of a negotiation that you do. There are some times where that battle has to be picked, and there are other times where you negotiate and you demonstrate your competence and your professionalism. And what I have seen is people who work closer with me, people who know my professionalism, are able to oversee the other things that they see right on the outside too. So I think it's a balance, it's a negotiation.
I can definitely relate to that trigger in terms of gender, I'm the chief OT where I am, and I have a male colleague, and as long as he's in the space, I will never be the chief of OT. They just always refer to him. I've had students, where, the patient turns to me and they call me nurse now, and he becomes the doctor. So those were my triggers for a while when I first became in the profession. But slowly I just, I shut it down, because like you say, you got to choose your battles. So I try not to be reactive. Sometimes I joke about it, but it bothers me sometimes still. So.
Can I talk about this from a slightly different perspective? I'm going to talk about something that happened to me when I was a student. And as a white person, other white people sometimes assume that I have certain racial biases. My family is interracial, my daughter's biracial, and people have said things to me about people of other races that I am totally offended by, but they assume because I'm white that I agree with them. So when I was in nursing school, I'm a nurse midwife, when I was in nursing school, the first week we had to do bed baths on each other. And I got assigned I went to Bronx Community College for nursing. So I was one of the very few white students in the class. It was mostly students of color. And I got assigned as a partner to do the bed bath. And she was another white student. And she said to me, "Oh, I'm so glad I got assigned you." And I never met her before. I didn't know who she was. All I could think about was I had to take my boots off, and I was wearing unmatched socks, and I was so mortified. And I couldn't figure out why she was happy to be assigned to me. I was just so nervous about this, and it made no sense. And then as the weeks went by, I noticed that all the white students sat together and did everything together, and all of a sudden it hit me, that's why she was happy to be assigned to me, because I was white. And I had to make a conscious decision. And the only thing I could do was not associate. And it's not that I didn't associate with them. I sat with them sometimes and talked to them. It wasn't like they weren't my friends. But I had to make a conscious decision to separate myself from most of the white students in that class, because I didn't want to be seen as somebody who had biases and didn't want to relate to people from other cultures. And it was I think it was the first time that had ever happened to me, but since then it has happened where people have made comments to me assuming that I share certain biases because of who I am, and I don't. And I had somebody call me up on the phone once when my daughter was first born to offer to come over and take pictures. "Oh, there's a promotion when you come take pictures of your daughter." And I said, "Well, I don't really know you. I don't want a stranger to come into my house." And she said, "Oh, we're going to send a really nice white man." And my daughter was a black child, and it was like, oh, what do I say? So I just hung up the phone. But, it's an interesting sort of it's just an interesting experience for people to make certain assumptions about me that are so not true. So I don't know, I've never had that experience with a patient saying something like that to me, but I have had it with other people.
Yeah. Go ahead.
Yeah, sure. I was just going to say, since this you can't really talk about this generally, right? This is more of a personal question. I would say, for me, it took me a while, and I'm very fortunate to have people, I have very smart elders in my life, and I have people who are wiser than me, and I listen to them. And one of the things they've helped me do over the years is to really understand what those triggers are, right? So that was the first step, because I had to understand what were the things that were both overt and the things that were covert, right? Because we think that, it's just, obvious, I'm not going to talk to you because you're a woman, you're black, whatever. But there are things that are said to you that people are not aware that they're saying it, but they are demonstrating their bias, their supremacy over you, whatever it is. So I had to be aware of that, and I was taught that over the years, and taught to get connected with my history, the history of the people who came before me that basically created who I am today. And understanding that and what that means in the world of today and how the world is structured and what that means for me as a woman of color. And so to be able to do that was a process, and it took some maturing, it took a lot of listening, and because of that, I'm able to not take those things personally. So when I am confronted with certain individuals that I can tell they're attacking me, whether it's overtly or covertly, I intervene when it is appropriate, and I make sure that, again, I don't take it personally. Why? Because I have an understanding of how the world is structured and what my role and what my place is in the world. So hopefully that's helpful.
Yeah, so I think, something that you're saying, Dr. Despert, is that you took time to understand. And it seems like a lot of what everyone has spoken about is you realize what your triggers are. And has that journey changed over time? If you look back to when you were starting out to now, and how do you react differently to these triggers? Because they are there, and even though we work on them, they've been instilled in us for a long time, from childhood onwards. So how do we make sure we don't respond to them, and how have you changed in how you do it? Or do you just find a punching bag sometimes and go at it? So yeah, how have you been able to do that self-reflection and that journey of transitioning of how you respond to triggers?
It's not always mature how I respond. Sometimes I cry.
100%.
Okay, I've done the crying, call my mom, but other times I will talk to, depending on who the person is. Sometimes I've spoken to the person to say, listen, I don't like the way how you made me feel. And sometimes they'll honestly say it was unintentional, but I think sometimes they need to be made aware also, so it's just not kept repeating. And the trigger for me, again, is when I go to meetings, they're mostly men, and I just feel like I am this, oh, do you have anything to say, that kind of stuff, so, and then I have another colleague who, a woman also, she is more, she'll get up there and say the stuff, and oh, she's aggressive. So, as a woman, sometimes we don't know how to approach stuff. I don't want to be labeled aggressive, and definitely not the aggressive black woman, because that's just a trigger for me also. But we get it, But I think, like I said, you need to, if you can, talk to the person. And I'm a spiritual person, so I definitely pray about things. I need that extra help, and so I do take it to my higher power.
Can I add something a bit more general? I think that in this panel, and often during many talks of this nature, you hear a lot of positive stuff. Be really open, be compassionate, and all of this great stuff. And I think it's really, really important to have that discussion. But what sometimes is sort of left out is, oh, we have biases where this is real stuff. This is raw stuff. This is going to bring up a lot of feelings. And most of you can agree with me. Some of those triggers never go away. You learn how to manage those triggers, but they will always be there. And the patients, or whomever it is that you're having that conflict with, is not going to be someone who you feel very comfortable even having that discussion with. They may sometimes be hostile. They may be passive-aggressive. When I was teaching at NYU, I had at least a couple of students in every class who sat back like this. There was nothing I could do or say to get through to them. And that was so hard for me. I really, really struggled with that. I stood up there and shriveled up and didn't know what to do. And I had to sort of, again, negotiate and say, this is a student I will never be able to conquer. They've closed themselves off to me, and that's okay. But that sort of will be a journey for you folks to have. It'll keep coming.
Anyone else on it?
I think I'm more willing to speak up, and I'll tell you a story about, this is a gender bias. When I was doing my doctoral dissertation, my committee was all men. And at one point, we had a horrible meeting, and I ended up leaving in tears. And then I went home thinking, oh my God, I'm the weak woman, how they must see me. I cried, and there were 4 men in the room, and I put my dissertation in the closet for a year because I just gave it up. I eventually did go back, that's another story. But one of my actual advisors said to me at one point, I don't remember if it was before the crying episode or after, but he said to me, well, I have to tell you, the reason I'm giving you such a hard time is because I really have a crush on you. And I did nothing. I said nothing. I ignored it. I pretended it didn't happen. He was a married man, and I mean, he didn't act on it, but the fact that he said that, nowadays, I would not have let that go, especially with the Me Too movement and the Time's Up. I would have reported him, but I ignored it. I let it go. I didn't say anything to him, and I didn't say anything. I just wanted to finish my doctorate, and I was so upset. But, and I did nothing. So I think now I speak up a little bit more. I try to speak up nicely, but sometimes I fly off the handle. I can get angry, and I have been angry in inappropriate situations even. But, anyway, okay.
So, we talk about, we've heard about discrimination or bias either towards us or how our patients have felt it. And there is a particular group, the LGBTQ community, who actually feels this drastically. Statistics show that 17% of them do not trust healthcare providers because of discrimination. And even especially in the baby boomers generation, 50% of LGBTQ American baby boomers are afraid for the same reason. And this is an astonishing percentage in this day and age. So what are things that we can do as healthcare providers to address LGBTQ mistrust in the healthcare on an institutional level, so a little bit higher up, and then also on an individual level? So I'll say that question one more time. What are things we can do to address the LGBTQ mistrust in healthcare on an institutional level and on an individual level?
So I just think it's how we set up the environment, right? So some of the simple things that they've been asking for are gender or gender non-specific bathrooms. And to me, that's a relatively easy fix. You change a couple of signs or, whatever. And if you have to knock down some walls, just make it happen. I don't think that's a very, on an institutional level. And also, I'm trying to figure out how to phrase this without giving up too much information. So I'll do this. On a SUNY level, they are talking about changing our language and how we are referring to
Asking for preferred gender pronouns.
Exactly. Thank you. And I was in a room with individuals that were having a very difficult time with this. And these were adults, professionals, clinicians, grown adults, and I was astonished by the difficulty that folks were having with that. And regardless, it's coming from an institutional level, so it doesn't really matter what folks personally feel about that, but taking that time, now going to the individual level, to use words they, their, and not being binary in your communication. So I think, if you just take a moment and pause and think about what you're going to say before you say it, you can't really go wrong. And making sure that you are, ask questions. Read, ask questions to say, how would you like for me to address you? And that is so appreciated. And I've done that. I wouldn't even say I did it on an interview, actually. So I interviewed an OT candidate and asked, yeah.
On the issue of the bathroom, I have to say, I went to conference this year in New Orleans, and in the conference, Center, they had a gender-neutral bathroom. Very few people knew about it, but it was always empty. So I think, like you said, those changes can be made much easier than most people think. I have to say, though, when it comes to the gender-neutral language, I feel like we need to have patience on both sides. Like, for me, I know sometimes I get it wrong, and I just need for the patient to know that it's not intentional. It's almost like reprogramming your mind, you know? I look at the fact, I have 2 kids, only 2, and their names are interchanged every day. You know, so I'm not making light of it, but I want to make sure that we don't get, the person making the adjustment isn't faulted and just perceived as just outrightly not trying to be sensitive. I think it's a mindset also for us, and I struggle with that, where sometimes there's a long pause when I'm looking at the patient. I'm like, you know, what gender should what pronoun should I use? And I am having a hard time with the they, because I don't understand how to use it. So it's education on every side. So I think, you know, I don't want to sound ignorant, but I need help with that area, you know, to understand that dialogue.
And to sort of add it to a broader level, I think when you're creating an environment where somebody from an GLBTQ community feels welcome, you also have to have more of a proportionate level of clinicians who represent the patients who are going to be seen. So again, at an institutional level, what are we doing to bring in somebody to this community, and what are we doing to make them feel comfortable, and what are we doing to sort of intentionally reach out to that particular audience? And I think the preferred gender pronouns still, like you said, make people uncomfortable, just because they don't want to get it wrong, and they don't want to say it the wrong way.
So I do want to ask one of your questions and ask it back to you. So we're talking about underrepresented populations, or within our programs within healthcare, the LGBTQ community, and also males. Even if you look at our panel, you look at our audience, where are the males in healthcare, and how is that affecting the health? No, we can't. We need them. They are valuable. Everyone has a valuable input. And so what are we doing to increase the underrepresented populations within the healthcare industry as a whole? Because it really is missing.
Can I say something controversial? So we sort of got these questions the night before to look at, and I think that this question is inherently flawed, because I'm not necessarily sure that men are underrepresented in nursing and PA and PT because of the fact that we're doing something to turn them away. I think that they're not represented here because men are supposed to be doctors, and these are not the kind of fields that typically, historically, right? So we can't think today. I see, specifically in the College of Nursing, you see more and more applicants coming from the male background, but historically, medicine is something that has attracted the male population. And so, you know, you'll hear women doctors who will complain, well, I walk into a room and someone calls me a nurse. Like, that's the perception. That's sort of what you see in media. That's what's been put out there. This is how strong culture is, right? Because that's what you think of.
So I guess as an institution, because we have a little bit more power in helping bring up these minority groups, how can we do that? Like,
I'm arguing that I don't think they're minority groups. Yes,
within
men. Yes. I think they're not choosing these professions. So.
And I think that when they are in these professions, they are not seen as the minority. So we see them, we're in these professions, so, you know, OT, right, we have less men, whatever. But then, exactly what Dr. Akhtar was saying, that when we enter a room, you even said it, that person's a doctor, you're the nurse. So no matter what, they are seen as a majority, because again, that's societal. That's not, we didn't create that. It's been created, and now it's just a matter of how do we intervene?
It's
how do we intervene, yes.
Exactly.
And
So
I
it's there, no matter what.
And I think for men to come into women-run or women-centered professions is seen as a step down, whereas for women to go into professions that are traditionally men, we're moving up in the world. And I think that that's been a problem. So I lost my train of thought.
Go ahead, Dr.
Yeah, I
Anderson.
think one of the first things you got to do when you go into a room is introduce yourself. I'm Dr. Anderson. That's the end of the discussion. I think, you know, part of communicating with each other. And therefore, the most important word in all of this discussion is empathy. And how do we learn that? How do we give it to one another, we give it to our colleagues, but it's that which has to develop for the love to be there so that you can do the very hard job that you're trying to do. And it's not just you. I mean, my sister was a hospice nurse for 25 years at Cabrini. And when the AIDS epidemic was there, she would go be sent out to some guy's house, and the guy would throw her out. He doesn't want a woman to touch him. So it's a communication thing. And so what we need to take some responsibility for our end of it, and the most powerful weapon you have is a smile. No one can yell at you if you smile at them. Because then they don't know how to react. So you tame them. I have had to tame little kids so I could examine them. So I've become a professional flirt when it comes to little kids so I can examine them. So, these are tricks that you will pick up as you try to do your job. But empathy is really, really an important word in all of this. Because then you learn to feel like the other. The Native American would say you got to walk a mile in your neighbor's moccasins before you know what he's going through. So I think that's a growing thing. You try to do that your whole life. Some people just never learn it, though. They usually become chairman.
I think those are such key words: empathy, kindness, and that's for your clients, for your coworkers, and also towards yourself, because this is a growing journey for everyone. I want to thank each one of you. We're going to open the floor to the audience if they have any questions. We have a few minutes for that. Yes.
I have a question. What Ronnie said about discussion with the 15-year-old patient, and she was mentioning the word Latinx. I mean, how did the word Latino transform into that word Latinx?
Well, I have mixed feelings about using it because I'm not a Latina. So, and I believe there's some controversy. So I said Latina, and then I said Latinx. I think you all know that you have in the Spanish language, and I do speak some Spanish. If you have 100 women in a room, it's a group of Latinas, and one man walks in, and it becomes a Latino. You can't say Latina anymore. So some people in that community have proposed that we give up Latino and Latina because it's inherently male-oriented, and instead use Latinx. Some of us who are not Latina or Latina, X replaces the O and the A. So instead of, it's non-binary. It doesn't, it's non-gender.
It sounds like you're trans.
But it is also, a cultural thing because that's the language and that's how people, that's their language. And so it's a little uncomfortable for me to use it until it becomes more. But I use both because I'm not 100% comfortable, but I get it.
I myself became curious about that. When I would see flyers on when I would see flyers in Bushwick, where I used to live. I now live in Rockaway Parkway and Wilmore Street, but when I used to live in Troutman Street near Knickerbocker, when I would walk through St. Nicholas Avenue, I would see flyers on different events, on like this place called the Bushwick Abbey. They would have like special grassroots events of some sort, and they talk, and it's primarily assembled by the Latinx community and things like that.
Thank you.
Thank you for your comment.
Dr. Lewis?
So you all are very experienced and seasoned in this matter of culture. So we have some students who are becoming seasoned. And so what do you suggest as initial steps that these students, many of whom will be graduating next month, what should they do starting tonight or tomorrow to really begin to grow in the area so they can be like you and even better than you over time, because they're the next generation, obviously, in terms of their effectiveness in dealing with culture? Just what are the first things they should do at this
Love your
point?
patience. Covers everything.
I would love to chime in on that. I think that one thing to do is to start recognizing your triggers And your triggers may not come from patients, it may come from a friend, it may come from a stranger, cashier, and start thinking about them and processing through them, because those triggers will keep coming up and up and up. And unless you deal with them, they will affect your career. So once you recognize them, like, oh, that nasty face that woman gave me, why am I still thinking about it 4 hours later, 4 days later? And then start going a little bit deeper. And it is a process, but once you start recognizing it, it won't affect you as much once you start claiming it.
I think the biggest thing is, the first thing I would say is just go with an open mind. I mean, just first see yourself and your patient as human, and then it becomes a better interaction. Sometimes I know at Brookdale, like I said, we're in East New York, and I've seen where we have our Jewish students from LIU, and they would come, and literally you have one group that can interact and it's no problem, and the other group that just stands back and look petrified. So they have to work with, like you said, it's the change is not on the side of the patient, it's on the side of the clinician. So I think they're going to have to just have an open mind and don't make assumption based on color or what's on television, or we're not all the same. Just treat us for who we are. Now, I've always been brought up saying treat people the way you want to be treated, but I now realize that's not how it is. You should treat people the way they want to be treated. So, yeah. So just have an open mind and really be aware of your biases. This is New York City. We're diverse. We're different. It's an awesome melting pot. Embrace it. Try different foods. Visit the different countries. With my colleagues, I love to travel. I go to their country and invite them to my country and so forth. And that's how you're going to kind of navigate the new clinician process.
And I think there's a lot of resources and help out nowadays because this has become an important topic and more people are aware of it. So there are books you can read. I'll give you one title. It's called When the Spirit Catches You When You Fall Down. And it's an amazing book. It's a very long book, but it reads like a novel. It's about the Hmong population in Vietnam. I think it's Vietnam, who immigrants from the Hmong population. And this child has a disease that they call when the spirit catches you and you fall down. We call it epilepsy. And it's a sad story, but it's a beautiful story because it's what happened to her in the Western biomedical healthcare system. Every healthcare practitioner should read it because nobody, not the family, not the healthcare providers, nobody had an ill intent. Everybody was trying to help this woman, but this young girl, she wasn't a woman, she was a little girl at the time, but they couldn't, their communication went completely over and they just didn't understand each other and the consequence was quite severe. So, and go online, look up the terms implicit bias and see what you can find to read. I mean, we can educate ourselves and learn about this area because there's a lot of resources out there nowadays. The other thing I would say is look at yourself and try to figure out, what cultures you come from. And I'm saying cultures with a plural. Because sometimes one of the problems with stereotyping is that we see somebody in front of us and this is what we see. We see black man, black woman, Asian person, whatever. And to them, they're a composite of many different things and not just what we're looking at. So figure out what your composite is and who you are, and that will help you also realize that everybody is many things. And most of all, we're all human beings, and I think everybody in this panel, even though we don't all know each other or we haven't discussed this before, I think we probably would all agree that we have more similarities than differences when push comes to shove, and that we're all human when it comes down to that. So just remember that and never forget that.
Another question?
Yes. So today, kind of to counter what you just said, today I had my interview with my Fieldwork 2 supervisor, and one of the things she said to me was, she said, you may have the experience that people may not want you to work with them because of the color of your skin or because you're not Jewish. So my question is, how would you, have you ever had that experience where someone outright rejected your services because of how they perceive you to be? And how did you handle it? And what tips would you have for someone who may encounter that as future clinicians?
Well, I've been called the N-word by my patient, and at first you're mad, and you're trying to process it. But the bottom line is you can't give in to it, especially if it's the patient. Basically, what I did was I had a supervisor who was very understanding, and in that scenario, I was able to say what was going on, and I was not the person to give the treatment. But what happens when you don't have any other person to provide the service? In that case, we had another therapist that could do it, but for me, it was hard, and I felt like I wasn't prepared, and I don't know if I am now if it were to occur again, but just know it's going to happen, and it's not just your patients who perceive you that way, also your colleagues. Sometimes, they're not saying it, but they definitely are thinking it, and how they respond to certain things that you do, and it's just for us, to somehow rise above it and show that we're more than just a color. Go ahead. Yeah, I'm so sorry. It's okay.
So I'm still a little stuck on what the fieldwork supervisor said to you. So I know that you jumped ahead and you kind of want a strategy, like what do you do in the real world when this happens? And so this is where asking questions is useful. So my question to this person would have been, have you ever supervised another black student? And if so, what did you do to help with that relationship? And so this isn't, and yes, I understand the supervisor, dynamic. You're just asking a question. Right, but that's still not saying what has she done in those situations. So, because you are a student and you need someone to help intervene on your behalf. So that's where I'm kind of stuck there, and it's hard for me to get past that. When you're out there in the world, yes, you're going to run into situations in which you will have to intervene. And the reality of it is, folks, we can only control our own emotions. We can only control what we do. We can't really control how people are going to, or what they're going to say. We can somewhat control how they respond to us, and that is through knowing ourselves and through the intervention. I just wonder, that goes back to asking the question, am I the only black student you've ever had? And has there not been another black therapist here? Like, those are the kinds of questions, and what do you suggest how I handle it? Besides just taking it personally, I'm not really sure how that would fit in my interactions with patients. So is there any way you can give me some more advice? And you're just asking a question or questions.
Can I just add something? I really sympathize and empathize with that, but I think 9 times out of 10, it's not going to be somebody calling you the N-word. It usually isn't going to be someone who says to you, I don't want you to be my caretaker because you're black. It's much more covert than that. And that's the really tough stuff. And it brings out all the, is it because I'm this? Is it because I'm black? Is it because I'm a girl? Is it because I'm young? Is it because I'm, recently? So much of your stuff comes up, and it's really, really hard. And it would be so great if we had a right answer for you, and we really don't. And it's something you're going to learn along the way, and you're going to struggle with, and you'll get your grounding. It'll always be hard, but it'll be something you get adjusted to as you sort of proceed.
And as a student, I think it might be hard to have the conversation. I think you should, but I think it might be really hard because she is your supervisor, your preceptor. She's going to be working with you. So you might want to speak to your instructors, who you are speaking to through this, they're here. But, you might want to take it to you're in the OT program. Yeah, you might want to take it to your OT instructors and say, look, this happened. What do you suggest I do? And see what their words of wisdom are from having to probably sent students before to that site and maybe even had the same experience. I don't know. I mean, it's hard for you as a student to undertake the responsibility, I think, for dealing with that. But your instructor should.
It's not only about being black. Gender is a huge issue, too, for some people. And being aware of that, you just know how to back off and step up. I mean, I remember a man looked like he was pregnant because he was retaining so much urine because of his enlarged prostate, but he wasn't going to let a woman catheterize him. So I'd go see him every hour. Is he ready? No. I thought, In the meantime, he's just right off the chandelier because he doesn't want anybody to touch him in his private parts. That was his issue. And I just had to accept that I had limits because of who I was as a woman. I was the only woman in my medical school class. Try that. So it's we all have our strengths and our weaknesses, and we just work around them. And sometimes we can't, and so we have to accept that. But you can always be kind, and you can always smile. And those things sometimes get you past these things. And I think some of the best health care is given by Black people who are taking care of the sick and the dying and are doing private duty nursing. I mean, the women who took care of my mother when she was in those extremists, I'll never forget it. And they were all people of color. They were all from the islands. They're from Haiti. Can you imagine? I mean, we just love them. And so, just being kind can sometimes let people grow beyond their bias.
And as your instructor, we're happy to have you come and speak to us personally to talk about any of these issues. We have one more question back there.
Actually, it's more of a comment. I know earlier you were giving suggestions as to what students can do to help be more culturally competent or deal with different issues. And I think one thing that I encounter with most of my students is the fear of asking questions. Will that person get mad at me? Will I offend them the way I ask the question? And I see it constantly because a lot of times people don't even want to ask me certain questions I think are important. This week has been difficult for me because everyone has said, oh, have a great Easter weekend. And I don't celebrate Easter. It's kind of hard to interject that somehow into a conversation, but part of it is, did you ask the question, what are your plans this weekend? Or, are you celebrating Easter this weekend? And knowing that it's better to ask the question than to make the assumption. Most people would prefer if you ask questions. They actually would like for you to ask questions as opposed to you making assumptions or avoiding. And that's the other thing I see a lot of students do. They avoid things that are very difficult. They avoid asking the tough questions. They avoid anything that might make not just the other person uncomfortable, but themselves uncomfortable, because that's something that takes a lot of maturity, a lot of growth, a lot of thought. And really, I think the most important thing is if you're doing it from a standpoint of being genuine, and you really want to help, you really want to know, and you really want somebody to feel comfortable, then just go ahead and ask. And the one last thing I'll say is,
our pictures.
Beyond just spirituality or religion, also, something that's very important to people would be their name. And I often see people afraid to say names that look difficult to them. So they won't even say the person's name. They'll just say her or him or whatever, or just don't interact at all because they're the fear. Again, ask, how do I say your name appropriately? Because if you can't even say the person's name, how can you help them? That's the most basic thing. A name is very important to an individual. If you can't even address that, how can you address anything else for them?
And can I add to that, Anika? I think that when you don't ask questions, it makes you come off as a little bit indifferent, like you don't care about the patient. Asking questions to the patient makes them think that you are invested in them and that you care about them.
We're going
And
to take
what's
one
the
more.
OT? What's the OT word for that, guys?
What is it?
An R. Rapport.
We're going to take one more comment or question from Dr. Lewis, and then.
One of the things we don't want to ask the questions is that's one of the best ways that you get people to start talking about themselves. We know that relationship is the single most important thing that equals a patient thinking that you're culturally competent, the strength of the rapport, the alliance and relationship. So human nature is, if I'm asking you questions, then you're having a chance to talk about yourself. The more you talk about yourself, the better you're feeling. And I'm learning, you're talking, our relationship is already forging and crystallizing at that point. So asking questions has many purposes, not the least of which is to help build that relationship, which is the single most important thing that you'll need to build that bond and for that person to feel like you're culturally effective with them.
Thank you. I think we're actually out of time, but we will be available for any further questions. I hope you guys got some answers, but I actually really hope you guys have more questions and more things to think about when you go home. Because as you can see, this is such a complex yet simple topic, and there's so many different ways to think about it for yourself personally and professionally. I want to say a big thank you to all our panelists for your words of wisdom and sharing your time and valuable insight.
Okay, so thank you all. Like as Professor Thomas said, thank you all for coming this evening. We are so grateful for all of our guest speakers. Thank you for volunteering your time to listen to these important messages that these women had to share.
Could I just say one thing? I want to thank you for choosing the OT profession. We need you.